Good evening, everybody. I'm Dr. Howard Elkin, the medical advocate. And thank you so much for joining me tonight for YouTube Live. November is American Diabetes Month. I decided to take this opportunity to share with you the enormity of this problem, of this epidemic, really. It's a great American epidemic, and it's getting worse. So in 2020, we have 34 million Americans with diabetes. That's about 10% of the American population. Now, about a year ago, I was researching this for a different presentation, and the numbers were like 30 million, and it was 9.4%. So just in 1 year, the incidence is increased by an additional percentage point. So it's pretty serious. Now, most of these people don't even, at least 21% of diabetics don't even know that they have it. And I would say that the majority of diabetics are inadequately treated, which is really sad. So we're going to discuss that tonight. And let me just, there's a distinction between type 1 or juvenile onset and type 2, which is adult onset. Type 1 is, usually we see this in children, and this is an autoimmune disorder in which there's damage to the islet cells of the pancreas. So they can no longer make their own insulin. They have to be given insulin for the rest of their lives. But type 2 is what we really see in practice. That's 95% of the adult population that has diabetes. They have type 2. And it's usually caused by something called insulin resistance or hyperinsulinemia, which we're going to talk about. But we're not just talking about diabetes, we're also talking about prediabetes. When we talk about prediabetes, the numbers go to 88 million people in the country today. So let me make a distinction. There's one test you really need to know about. It's called the hemoglobin A1C. And that is a test, simple blood test that your doctor can order. And it actually is it's a marker on the red blood cell. And it tells you exactly how well your blood sugar has been controlled for the previous 3 months. And it's a great monitoring tool. So everybody needs to know their number. So here's how we define it. If you're less than 5.7%, you're not a diabetic at all. If you're between 5.7 and 6.4, then you are a pre-diabetic. And if your A1C is greater than 6.4, you are a frank diabetic. And as the numbers rise, it tells you that the disease is actually more serious. So it's really important to know your hemoglobin A1C. Now, there's also something called metabolic syndrome, which you've probably heard about. That's a cluster of five conditions. Number 1, increased blood sugar. Number 2, increased blood pressure. Number 3, decrease in HDL, or the healthy cholesterol. Number 4, increase in triglycerides, which is one of the blood fats. And number 5, truncal obesity. And I mentioned metabolic syndrome because I must get about at least 3 or 4 patients a month with newly diagnosed metabolic syndrome. So metabolic syndrome, prediabetes, and diabetes are a huge subset of our population. And it's really part of this, it's a continuum. It's part of the same problem. And the numbers are growing, as I've mentioned. So it's a very serious condition. So why is it so serious? Because 70% of diabetics will have a stroke or a heart attack in their lifetime. So actually, as a cardiologist, we treat a diabetic as if they already had a heart problem, even if they don't, because we know that the chance of it happening is pretty likely. Now, besides that, there's other conditions. There's a retinopathy or blindness, very common in diabetics. There's painful neuropathy, which is damage to the nerves in the lower legs and the feet, and kidney disease. In fact, the most common cause of people undergoing dialysis today is diabetes. So it's a really big problem. And I think I'm always asked this question, like, what is the best treatment for diabetes? Always I'm asked that question. And here's the answer. Prevention. Prevention is always the best treatment. And I've told you the bad part of the disease, but there are a couple of things I want you to also know. There's a high incidence of cancer in diabetes. So there's a link, and although not really fully understood, it's more common in women. So women have a 29% more likely to develop cancer than a non-diabetic woman. And in men, 19%. Diabetic men are 19% more likely to develop cancer in their lifetime. One other problem is Alzheimer's. There's definite correlation between diabetes and Alzheimer's disease, and we're pretty sure that has to do with insulin resistance. Insulin resistance means your body doesn't really recognize your own insulin or doesn't utilize it. And insulin is secreted every time you eat a meal from your pancreas. And its job is to shuttle sugar from your food, from your diet to the muscles and to the liver for storage. But if your cells don't recognize that insulin, it doesn't allow it in. It's like kind of a gate, a lock and key concept. That doesn't happen, then the sugar remains in the bloodstream, which isn't good. And then more insulin, the body produces more insulin. That's that whole term hyperinsulinemia. So the things you need to know about, you want to know your A1C number, very important. And you also want to know your your fasting insulin level. And that gives us a good chance of what your risk is. So let's talk about treatment. I already said prevention is the best way. And my emphasis here is lifestyle, always lifestyle, and it's diet. So I don't care whether it's vegan, Mediterranean, paleo, ketogenic, they all have their role. But the important thing is that you need to have a low carbohydrate diet. And you need to know that just a few years ago, the dietitians really were still recommending these things called exchanges. And with diabetics, we're not really imbibing on a low carbohydrate diet. So we have to be ahead of the game. Like with low carbohydrates, starchy carbs is really it's de rigueur when it comes to treating diabetes. And of course, exercise. I mean, that's the combination. It's weight loss through diet and exercise. That is the winning combination in treating diabetes. And so I want to leave you with like a little case study. A person I know quite well. So this person had a hemoglobin A1C of 7.2. This is about 3 years ago. And because he's got kidney disease, he really couldn't take a lot of the medications that doctors would have wanted to put him on for diabetes. So he had a choice of either shooting himself with insulin all day long or really watching the diet. So he really cut out his carbs tremendously. No bread, no bagels, no pasta, no rice. And in just 2 months, his A1C went from 7.4 to 5.4. That's pretty remarkable. It can be done. It's a commitment that needs to be done. So now I want to hear from you. So questions you have, put in the chat box and I'll do my best to answer them. Okay. I'm a diabetic with severe kidney disease. Can I be a candidate for the new weekly medications that you use once a week? Okay, what he's referring to are these GLP-1 agonists. It stands for glucagon-like peptide. And they're great medications because they also delay gastric emptying, so you end up eating less. So it does help you to lose weight. Except that, these medications aren't, if you have kidney disease, you're kind of, you really aren't a candidate for it. That's the problem. A lot of these new medications, and there's some good ones out there, really are kind of not disallowed in the people with renal disease. So you can take it, but if your creatinine clearance, is less than, I think, 35 or 40, you aren't a candidate for it. So I hope that answers that question. Okay, more questions. One question I'm frequently asked is, my doctors, this is a good question that came out recently to me. One of my patients said, well, my doctor said my A1C is 8.2. He said, that's okay. And this is a diabetic specialist he's going to. And I have found that diabetic specialists and endocrinologists are not always as aggressive as I am. So I said, no, 8.2 is not good. And the problem when you go to a regular endocrinologist, and they're very knowledgeable diabetes, believe me, is that they don't really emphasize the lifestyle part and the diet part. The person I'm talking about was very heavy, has to really embrace lifestyle. So I always start with lifestyle, diet, weight loss, and exercise. And it's really a must. So 8.2, 7.8, 7.4, none of those are good. You want to get as low as possible. And I'm really strict about that. Okay. Is the magic A1C number. Okay. So, no. Okay. The A1C number that I shoot for, thank you for that question. I try to get my patients to be in the non-diabetic range. So let's say pre-diabetes is 5.7. I try to make my diabetics or pre-diabetics. I try to get my pre-diabetics in the non-diabetic range, low as possible. You can't get too low when it comes to your hemoglobin A1C. So, but once you're up to 6.4 and above, you are a frank diabetic, and we really don't want that. Okay, moving on. How much of a metabolic issue would you say are based on Boy, okay, that's a great question. How much of metabolic issues are based on habit as opposed to genetics? They both play a role. Um, there's a recent study that came out that I'm going to talk about in my next blog, and from the University of North Carolina, and they found that 88% of the American population is metabolically unhealthy. We alluded to this when I was doing my talks on COVID, because these are the high-risk patients. So what am I talking about metabolically unhealthy? Well, diabetes, prediabetes, metabolic syndrome. These are the syndromes that we see. And there is a genetic part. I would say genetics is like 20% of it, and 80% of it is lifestyle. There's so much we can do with lifestyle. Your genes are your genes, but you can go past them with lifestyle. I fervently believe that, and I've seen it. Okay. How can someone like my ex, who is super thin and athletic, be diabetic? That's a good point. You do see it. Most adult onsets are overweight, but you're going to see some that actually are thin or slender, and that's probably genetic. Probably a high correlation between that. But also, you got to look at their waist. Okay, I didn't mention this, but you can be normal weight. Like I have patients that say, "Well, I weigh the same thing now as I weighed when I graduated high school." Yeah, but look at your body composition. Has it changed? And usually does change with age. What we measure is this thing called waist circumference. We want to measure your waist. Okay, if it's greater than 35 in a female and greater than 40 in a male, that's high risk. And we know from previous things that I've talked about that belly fat, you have all these inflammatory things called cytokines, which is really puts you in a poor direction as far as aging is concerned. So, you can see it in thin people. It's not the norm, but it's definitely there. Okay. More questions. I thought of something else. Okay. It's another question I was recently asked. What about a ketogenic diet? Is that good for this disorder? And, I got to tell you that ketogenic diet may not be the easiest diet to follow, but it's very good for diabetics, prediabetics, metabolic syndrome, and weight loss in general. You will lose weight, and you will improve your A1C, your insulin levels will decrease, and you will have less inflammation going on. It's the opposite of what we used to do. So instead of in the 90s, some of you might remember everything was high carb, low fat. And that seems to be the basis of this problem today that I call an epidemic, because what happened? The country got fatter, and now we have more diabetics than ever before. So that was all wrong. So we need to go reverse. So with the ketogenic diet, there's very little sugar, very low carbs. There's different forms of it. But the low carbs itself and substituting fat for the carbs seems to make a major difference. It's also a good diet for aging, because the brain thrives in the presence of fat, not carbs. So I don't push that diet. I want you to know that. I'm more into a low carb diet, somewhere between Mediterranean and paleo, but some people do very well with ketogenic. So I wanted to mention that as a possibility. Okay. Would you say metabolic issues have become exacerbated in lieu of COVID-19? Yes. Yes, they have. I've had patients in my office come in saying, well, I've gained 5 pounds. Well, I've gained 10 pounds. I've gained 20 pounds since COVID-19. And I was very vocal about this on social media from the very beginning. It's like, do not use this time to get into comfort food. I know we all want to do it because it's easy. But the thing about comfort food and sugar, okay, is that sugar will compete with vitamin C for your immune cells. And we don't want sugar to win the battle. And that's what's happening. So yes, people have definitely gained weight. I've seen a lot of it, and I've seen the A1Cs go up. So it definitely exacerbates it, unfortunately. Okay. Is it true that you have a day when you eat sugar, the sugar takes longer to metabolize? Eat a sugar. I'm not quite sure I get that one. Oh, Okay. Okay. Sugar is metabolized very quickly. I don't know if I got the right question, if I have the right. Um, hmm. Okay. If you eat carbs with fat, you're going to decrease the absorption of the sugar, so it won't be absorbed as fast. But that's the whole thing about whole wheat pasta or whole wheat bread or brown rice versus white rice. It's still going to boil down to sugar. Sugar is sugar. It will be dissolved, absorbed much slower, but it will eventually be absorbed as sugar. So it's the same thing. I know that answers your question, but it makes a difference as to what you add it to. Okay, let's see. Sugar and yeah, sugar and fat. Hey, let's see what other things. How about questions about diet? Okay, does that cause a spike in your insulin? Yeah, okay. So let's go over this whole thing about insulin. So insulin is a hormone that your pancreas puts out. Every time you have a meal that has any carbohydrate in it at all, your pancreas is going to secrete the insulin. And the insulin has a very important job, and that wants to shuttle the nutrients, specifically the sugar and the fat, to out of the bloodstream to where it belongs. So we want it to go to the muscle cells and the liver cells for storage. But again, if you have insulin resistance, that's not going to happen because that lock and key isn't working well. So it doesn't allow it in. So then your pancreas will make more insulin, and then we have that hyperinsulinemia. So that is the culprit. That's the problem. Okay. So that, yes, you'll get a definitely spike, which isn't good. Okay. Could you expand on why natural sugar is better than added sugar? You know what? Sugar is sugar. I don't care how you look at it. Syrup, honey. I mean, there are healthier forms, but if we're really interested in watching our and really avoiding diabetes and pre-diabetes and really the thing is just to go low carbs and definitely avoid the simple sugars for sure, because they're all simple sugars and they're going to be absorbed very quickly. Can a diabetic eat fruit? Yes. Okay. Let's talk about fruit. Fruit's great, but different types of fruit. The healthiest thing for a diabetic, pre-diabetic, or for all of us actually, things like berries. All berries are good. Strawberries, raspberries, blueberries. All the berries are very low. We do this thing called a glycemic index. Now, when I talk to my patients, I tell them I don't talk about grams, I don't talk about calories, but I do use the glycemic index. So every carbohydrate has a numerical value. And for example, table sugar has a value of 100. Baked potato has a value of 90. So eating a baked potato is kind of like eating a spoonful of sugar, right? But the berries are in the 20 range, which is very low. The fruits you want to watch out for are like the melons. So watermelon, cantaloupe, honeydew, they're all pretty high in sugar. But citrus fruits are good. Apples and pears are good. So you do have some good choices there. And when it comes to vegetables, probably know that corn is a starch. That's break down the sugar, and also beets, which are very healthy. But you have to consider that. Okay, sorry, I have to wear my glasses on. These are really small print. Other questions. Here we go. Color in choosing food. That's a great question. Yeah, you want to use as much color as possible. That's why I like like green peppers, yellow peppers, orange peppers, because a diverse color like palette actually it makes it more anti-inflammatory, and we all want to have an anti-inflammatory diet, so that's really important. Okay, let's see here. Camera looking real clear. Oh, thank you. Yeah, this is a new computer system I'm using, and I really like it, but unfortunately I have to put my glasses on to read the questions. Okay, we have a few more minutes, so I'm trying to think of anything else I want to discuss. Okay. Purples and blues, yes. Are they the best? I don't know if they're the best. They're very good. They're very good. there with those purple potatoes. I forgot what they're called. Yes, people have really praised them. I don't know how much better they are. I think the important thing is to have a wide palette with lots of different colors, whether it's purple, blue, orange, or yellow. The wider the palette, the better it is, and the more anti-inflammatory it is. What about sugar substitutes? Um, Sugar substitutes are okay. They're not great. I mean, they are substitutes. I suggest stevia is probably one of the better ones because it is from a natural. It's from a tree actually, as opposed to the pink stuff or the yellow stuff. So it's probably better than having sugar, but it is a sweetener. It's an artificial sweetener. So I think with diabetics, you have to have something. You can't cut out everything. I understand that diet can be overwhelming at times, so I'll allow for stuff like that. I really do. Okay, let's see. Anybody else? Is it harmful to use sugar substitutes? It can be, and I'll tell you why. It's been shown in certain studies that eating a lot of sugar, a lot of substitutes can actually increase your appetite for sugar. Can you believe that? It makes sense, right? Because it's a sugar substitute, so you want to eat more. So there's also an increase in metabolic syndrome. People gaining weight off of sugar substitutes, and we know that metabolic syndrome is kind of a precursor to prediabetes and diabetes. So that can happen. It's been reported in the literature. Okay. We haven't talked, no one's asked about exercise. And exercise and weight loss are really important components of lifestyle when it comes to treating your diabetes. So I'm a firm, I get people to do exercise. I will check them out and we'll make sure they can exercise. We might do a stress test first because I want to rule out heart disease, heart problem. But then I will give them an exercise prescription and expect them to follow it. People that stick with me generally want to choose lifestyle as their method of choice, their treatment of choice. And it doesn't matter whether it's aerobic or weight or resistance training. I think we need both. I think as we get older, strength training has a much more important role because of bone health and muscle preservation. People that end up in nursing homes because they can't open a window, they can't open a jar, they can't shut this. And so we really want to maintain strength. And that's why I'm so big on weight training, and I'll probably do a talk on that one of these days. Okay, what strategies you have in defeating sugar cravings? Good point. One of the best things is fat. Okay, see, that's why ketogenic diets can be so helpful, because fat gives you a sense of satiety, whereas carbs, you just want to have more, right? So I like natural peanut butter. That's like when I would have a craving. I have less cravings now, but when I used to have a craving, I would have like a tablespoon of natural peanut butter, and that seemed to help me. Again, because it's natural fat and a good source of it. It's very important, though. Okay, sugar cravings. I'm saying, did I miss anything here? I deliberately stayed away from medications and so forth because that takes it into a whole different realm. Now, as a cardiologist and someone who's very proactive with my diabetics, I treat them. I treat all my patients that once they require insulin, I do turn them over to an endocrinologist because that's a whole different ball of wax. And there's a lot of complications just with taking insulin, but sometimes you need it. And that's really important. And one of the things I measure is another test called a C-peptide, which you may or may not have heard of. And that tells me how hard the pancreas is working. So if the pancreas, if the C-peptide is high, that means that pancreas is working really hard to keep your diabetes in check or your metabolic syndrome. But eventually, that pancreas can poop out, and then you actually need insulin. So we don't want to get to that point. That's why knowing your A1C, knowing your fasting insulin level is important. I do see peptides. It's not what the average doctor would order, but it does help me to help you more. Let's see, what suggestions do you have in defeat? Oh, that was sugar crave. You talked about that one. I guess that's about it. Okay. Well, that was it. So this is American Diabetes Month, and I thought it was, oh, here's something here. Okay. Have you ever seen people with diabetes revert back to normal metabolism? Absolutely. Absolutely. And it's all based on what we've talked about, really. It's the diet and exercise. And diet itself is going to, exercise will increase your metabolism. Okay. Weightlifting for sure, aerobics will as well. So it's really important to combine those. And with diet, yeah, I've seen major reversals. Yeah, I told you about the one who went from 7.4 to 5.4 in just 2 months. Usually it doesn't happen quite that fast. It's a slow process, but lifestyle is really everything. I've had diabetics become non-diabetics. I mean, it's not a curable disease, but it's very treatable. Same thing with hypertension. We want to be able to, it's not so much curing a disease, it's actually treating it so that you become a normal person or close to it. Does cholesterol have anything to do with diabetes? Not really. The emphasis in my field as a cardiologist has always been fat and cholesterol. And you see where that got us, right? Like I said, that was the big thing in the 90s, was everything was low fat and high carbs. So I don't think cholesterol really enters the picture so much. I tend to spend less emphasis on it unless I'm dealing with a patient that has heart disease. And diabetics, like I said, we treat as if they do have heart disease. So I am more strict, but I don't think cholesterol itself makes diabetes worse, if that's your question. They're kind of independent processes here. Okay. So type 1 is a whole different NA. You don't ask about type 1 diabetes. These people lack insulin from the time they're diagnosed, really. So it's an autoimmune disorder. So they have to be treated as such. So they have to shoot themselves with insulin. And that's when a good endocrinologist comes in handy, because it's using there's different, when I was an intern and resident, there were like 2 different types of insulin. Now there's numerous types. So it really helps with these juvenile onsets or type 1, because they can inject some of the insulins last longer than others. It's knowing when to use what when. Okay. I think we've pretty much used up the half hour. So great. Thank you for your attention. Keep in mind, everything that we say here is not to be taken as a blanket statements. That you always to check with your doctor regarding information here. Information here is just a suggestion. It's information only. It's not a treatment program, so to speak. We won't be present in 2 weeks because it's Thanksgiving. So the next time we have a session will be I believe it's the 12th of December. Okay. The 12th of December, and we'll be made aware of all that. We'll make sure everybody knows. So, okay, listen, wish you all a happy Thanksgiving, and we are in holiday time now, so please watch the carbs, all right, and exercise after you eat. Enjoy your holiday. Thank you. Thanks a lot. We'll see you then. Okay, end it, right?
Yes.